So yeah, you already mentioned it a little bit. I got my law degree in 1889 and I studied law with the idea to become a diplomat. And then I realized that I would never be a very diplomatic person, and so I joined a rather undiplomatic organization called MSF, the Doctors Without Borders. And I spent about 20 years with them in different positions. And I left MSF not because I disliked what MSF was doing, but because I felt that the humanitarian system, which is perhaps part of global health governance, was overstretched. It was doing things that should not be done by humanitarian aid. Crises that could have been avoided. And for me, the big example was HIV/AIDS. I completely agreed that at that time, HIV/AIDS was a humanitarian crisis, but it shouldn't have been. We knew sufficient time in advance of what was coming, and the world was ill prepared for it and didn't react as it should. So what I call the global justice and peace next to humanitarian system didn't do it. And that's not over, unfortunately. I mean, we all know that we will see more and more humanitarian crises due to climate change. Hunger, famines, droughts, etc. Things that are avoidable, would have been avoidable if we reacted to climate change 20 years ago. And my prediction is that the humanitarians and the MSFs will have to intervene, and that wasn't necessary. And even inequality in the world and poverty, I think there are structural causes of that, and humanitarians cannot change that. So that's why I left and became an academic, or sort of. And the first thing I did was to go to study philosophy. And so as a lawyer, you have a little bit of that. But I wanted to go deeper into ethical questions. I mean, I like the slogan you have on equity, but what does equity really mean? It refers to justice, and what does justice or health justice really mean? It's not so obvious. Then I went to the Institute of Tropical Medicine in Antwerp, and since 2 years I'm at the London School of Hygiene and Tropical Medicine, and I'm a professor of global health law and governance. So, a brief introduction to global health governance. I cannot explain the whole mechanism, but how it works, there are broadly two ways to influence it. Decisions taken at the global level with regards to health. One is with voting rights, and the other is with money. And sometimes, or most often, they work together. When you think about voting rights, you have different mechanisms. You have the WHO, where each country has one vote. And then you have the World Bank, where each country has a number of votes related to its money, how much money it gave to the World Bank. So the rich countries have many more votes than the poor countries, to put it simply. And then you have new mechanisms like the Global Fund that are kind of in between, where half of the votes are to the so-called donors, which I think is a problematic expression in itself, and the other half to the recipients. So 1 billion people get half of the votes, and the other 6.5 billion get the other half of the votes. Not really democratic, but if one country, one vote is perhaps the ideal, it's not entirely democratic. That's how WHO functions in principle. But actually, WHO cannot force countries, states to do what they decided democratically together, because it doesn't have the money and it doesn't have the power to do that. So when WHO tried to promote the right to health, the famous declaration of Alma-Ata, some countries disagreed, and they shifted their money to the World Bank, and the World Bank became a big player in aid, and the voting rights are very different. So you can have a mechanism that seems fair on voting rights, but if the money is not there, then it doesn't really work. And so that's something to take into account. You have to be a little bit pragmatic and principled at the same time. So coming back to the philosophical question or the ethical question, it's easy to criticize global health governance as it is, but it's not so easy to say what the right global health governance would be, because the underlying question is an ethical question. Who is responsible for people's health? And once you have the responsibility, you can start organizing this. But that question remains unanswered. We all agree that there is, at least to some extent, an individual responsibility. If you behave in certain ways or don't behave, that has an impact on your health, that's your individual responsibility. There's a responsibility of the community, and there's a responsibility of nations or states. And we accept that, but it's actually relatively new. The NHS is not 100 years old. And before the NHS, there was no national responsibility for health in this country. There was individual responsibility, there was responsibility of communities, of parishes, of companies to some extent, but the citizen of London was not responsible for the health of the citizens of Cambridge and the other way around. Now we find that strange. And now we use expressions like the postcode lottery, which I find a very interesting expression to say that depending where you live in the UK, you have different entitlements. And the fact that we have this expression signals that there's something going wrong. We don't accept that people living in different cities or villages in the UK have different entitlements. And so it needs to be corrected. But do we have the same at the global level? Do we accept that if your telephone number starts with 44, you have 10 times as much entitlements as the person whose telephone code starts with 265? We kind of take it for granted. We kind of accept that if you live in Malawi, you don't have the same healthcare as a citizen of the UK. And so we're not really clear about what this responsibility is and what global equity really means. Does it mean that everyone has to have access to the same level of healthcare? How do we organize that? And the activity we see in global health, all the money spent, all the activity, is actually misleading because it suggests that there is a global responsibility. We think all these organizations exist because the international community has accepted the global responsibility. But if you dig a little bit deeper, that's not the case. One important reason why these institutions exist is essentially charity. And charity means the absence of responsibility. I can give you the day I feel like giving you. The day I don't feel like giving you, I don't have to. I don't have a responsibility. If, for example, tomorrow Boris Johnson becomes the next Prime Minister of the UK, then we can expect a reduction of UK assistance for global health, because he said so. And the UK taxpayers can decide together. That is charity. That is refusing responsibility. The other big part of global health is, I would say, enlightened self-interest. We support healthcare in other countries because we don't want Ebola to come to London. It's not a coincidence that all these big global health institutes or international health institutes are in ports. In Antwerp, the port of Antwerp, there is a colonial legacy behind it. And there is a reason why we want to stop AMR from coming here. There is a reason why we want to stop multi-drug resistant TB from coming to the UK. That is not global responsibility. That is taking responsibility for your own citizens by doing something in other countries. And what is actually the responsibility? That's not settled yet. And I've seen on the presentation, and I saw before that Sridhar Venkatapuram was here a couple of weeks ago, talking about the right to health. If you accept that health is a human right, then the corresponding responsibility falls on humanity. And then you need to look at global responsibility for health in a completely different way. And then you can start thinking about global health governance to realize the right to health. And then you will come up with completely different structures. Now that's not going to happen anytime soon, but thinking about global health in this way is a first step. It's acknowledging that we should not only have a global fund to fight AIDS, TB, and malaria, which happen to be infectious diseases, and that we don't have a global fund to fight maternal mortality, for example. If you use a right to health perspective, that's not acceptable. If you don't do that, if you accept that the responsibility of nation states, that the responsibility for people's health is individuals and nation states, then there is no problem with global health governance. Then the global health governance we have is working perfectly, because it does allow every country to say, I will help the others if I feel like it, and I won't if I don't feel like it. And then it's not problematic. So you really need to challenge that. So what to do? I don't know what to do. I don't know what you should do. I know what I'm trying to do. And it's partly having this kind of discussions and hoping that the next generation of people in global health will truly embrace global responsibility and not just enlightened self-interest or charity. The other part is that I'm trying to work a lot with ministries of health of low-income countries, and I'm actually telling them to be opportunistic. If you understand that one of the main reasons for this global health cooperation is enlightened self-interest of the richer countries, use that, negotiate it, and say, okay, you want global health security, you want to stop Ebola, we will tell you how we want to do it. We will do it by strengthening our health system, and you will support that or not. But we won't tolerate these vertical interventions that are only focused on infectious disease control, etc. And that is starting to happen, and that's what is making me most optimistic today. Not so much what is happening at the global level. There is a new global action plan on SDG 3. We've seen that before. Some people are more optimistic that this time it will achieve something. For me, the real game changer is when countries are starting to say, you want to eradicate polio in our country? Well, you're going to do it our way, through strengthening health system, through this and this and this. And that, I think, is a reason to be cautiously optimistic. And I think my time is up. Thank you.
Yeah, food for thought there around global human rights, citizenship, whose interests are really we're protecting in our global efforts. So moving on to our next speaker, Professor Sarah Hawkes. She is a Professor of Global Public Health at UCL in London, where she leads a research team analysing the use of evidence in policy processes. She's published numerous articles on the extent to which global health organisations are gender responsive. For much of the last 20 years, she's worked in Asia, gathering evidence and developing policy for programmes focusing on gender, sexual health, non-communicable disease and human rights, while working closely with national governments, WHO and the UNFPA. Between 2012 and 2014, Professor Hawkes was the Wellcome Trust Senior Fellow in International Public Engagement, focusing on the use of public engagement in policy processes, and she now leads the newly established UCL Centre for Gender and Global Health. Thank you very much, Professor Hawkes.
Thank you, and thank you for inviting me. And it's always one of those embarrassing moments where, despite the fact I live just a short cycle ride away, I was, of course, the last person to arrive. So I'm very glad to be here on time. And I want to just follow on from a little bit of what Gorick said. And by way of Gorick's introduction, he gave you some introduction to his background. So I'll explain a little bit about how I got to be standing here. And how I think that has influenced the direction of my career. So I, like Gorick, I mean, I think we're sort of just representative of the incredible privilege of being a couple of generations older than you and being able to benefit from universal free education beyond tertiary level. And so, like Gorick, I stand here with several postgraduate degrees in sociology, in medicine, in epidemiology, and in policy, able to draw on those theoretical backgrounds and then spend many years working at country level, from village to capital at country level. Just sort of seeing whether any of those theories were right or wrong or perhaps needed a bit of revision. And I like Gorick, have ended up in academia partly really to further my own understanding of why, when we've got so much evidence about what we should be doing, because we know what we should be doing, we don't need to spend millions and millions and millions of pounds, dollars, euros, whatever, to tell us what we should be doing, but we're not doing it. And so I've spent my time since arriving back at UCL, where I did a medical degree many years ago, trying to understand what the link, or in most cases lack of a link, between empirical evidence and policy processes looks like, and why that gap is there. And that studying that gap really has led me into a range of different areas, some of which touch on the issue of global health governance, in relation to some of the empirical evidence that will become even stronger and more important when you're in your careers in global health. So I think both Gorick and I, and possibly Mike, although Mike's quite a bit younger than Gorick and I, so this might not be true. And I'm not going to speak for David, because I know David comes from a different sector, that I think what shaped us early in our careers was the HIV epidemic. So I started working in HIV in 1984 and stuck with it until the early 2000s, and then spent a lot of time realising that that really wasn't just the world that was undergoing an epidemiological transition. My own interests were going a transition too, and so for the past number of years have focused mainly on the role of NCDs, non-communicable diseases, which could just be a function of getting old. When you're starting your career, you're just interested in researching sex. You get to middle age, you worry about heart attacks. By the time I end my career, I'm sure I'll be researching dementia if I'm still around. So perhaps it's the trajectory you'll all go through, but I suspect that it's also driven by the fact that the epidemiology of what you're all going to have to go out there and deal with has changed significantly over the past 20 years or so. And I think that where that leads me, and it's sort of ironic really to hear somebody trained in philosophy and law stand here and talk to you about the health system and the right to health, which frequently is understood as the right to health care. And I'm not suggesting that that's the way Gorick interprets it, but it is the way many people in global health interpret the right to health, is the right to health care. And so as somebody who's trained predominantly as a public health specialist, a global public health specialist, I'm going to try and persuade you in the remaining few minutes that what you should be interested in moving forward in your careers is the governance of the governance for health, not the governance of the health system, which Gorick has very eloquently outlined is very complex and difficult and is subject to a number of vagaries, but governance for health, by which I mean that the vast majority of population health levels are driven by social, cultural, economic, commercial determinants. They're not driven by people's individual risks. They are manifest through individual risks, but those individual risks are driven by structural level determinants. Those structural level determinants are driven by politics. So we've known that in public health, we've known that since the beginning of public health, really. If you look back at the history of public health, if you look back at the big change makers in public health in going back to Victorian times, what they were interested in wasn't setting up more and more clinics. It was in addressing the social, structural, economic, political issues that made people sick in the first place. And so what I want you to think about moving forward is how you as a generation are going to address the governance of those determinants. Because I think once you start to think about the governance of those determinants, by their very nature, you have to think transnationally. These are not determinants that are driven by the activities of individual nation states. They are determinants predominantly driven by the activity of people making a profit. And those people making a profit are the transnational corporations. So whether we're talking about health as an outcome, health inequities as an outcome, climate change as an outcome, air pollution as an outcome, no matter what your big problem of the day is, it's the activity of the unregulated market that is driving risk for everybody. And that market is not contained within the borders of individual countries. That market, by its very nature, is a transnational market. So the top 6 or 7 beverage companies, by which I mean the alcohol industry companies in the world, are worth more than the economies of the bottom, the individual economies of the bottom 100 and, where are we in the world, 196 countries now? The bottom 176 countries, none of them have an economy that matches the top 5 alcohol companies in the world. So when we're talking about regulating the determinants, governing the determinants of what actually makes people sick, what I'm talking about is diet, processed food, ultra-processed food, the rubbish that people eat because they haven't got access to fresh, nutritious food. I'm talking about tobacco, which might be on the decline across much of the OECD countries, but is still rising, and particularly rising amongst women in low and middle income countries. I'm talking about alcohol, I'm talking about air pollution. All of those factors are being driven by market-based companies that are outside the control of the vast majority of governments in the world. So if we seriously want to talk about governing public health, global health, what we actually have to start figuring out as a community is how we are going to regulate and hold accountable the private sector. We don't have good models for that. There are 3 suggested models. One is you let the private sector get on and do it by itself. Self-regulation. Private sector, we will put those green triangles or red blobs on the front of a cereal box just so that children know they shouldn't have too many Frosties in the morning. That's a very typical private sector response to the notion of regulation. We'll do it ourselves. It's a voluntary activity. Aren't we wonderful? The next option is that you try to get the public and private sectors to work together. And for anybody who's worked with the UK public health community will know that that's like trying to sell a lead balloon to the public health community. They refuse to even sit at the table with the private sector. The third model is that you rely on nation states, on individual governments to regulate the activities of these companies. And we have really almost no models where that is working. Historically we have had, but right now we do not have any idea really how to bring these companies under control. So in terms of global health governance, have I got a solution? No. Hopefully, as Gorick said, you will come up with some solutions as you move forward in your careers. But I really would like you to be able to go away from tonight and think it's not just about seeing the health sector and the right to health in a different way. It's about seeing what determines health and what makes people sick in the first place that we really need to think about bringing into the world's governance structures. Thank you.
Thank you very much. That was fantastic. So next speaker is David Archer, who is Head of Participation in Public Services at ActionAid, their primary aim is to work against poverty and injustice worldwide using a human rights-based approach. David Archer has 25 years of experience working on rights-based approaches to education, supporting civil society organisations across Africa, Asia and Latin America. He co-founded the Global Campaign for Education. He's chair of the board for the Right to Education Initiative and is a long-term elected member of the Global Partnership for Education. He's developed also ActionAid's framework for gender-responsive public services, looking to harmonise approaches to the financing and delivery of health, education, water, agriculture and other services. And he's also looked at the parallels between global and domestic financing of health and education systems. Thank you very much, David Archer.
So I'm basically the imposter. I'm not really from a health background at all. I come from an education background principally, but I'm more and more convinced of the interconnections between health and education and in the way that we need to make both global and national responses. And if you look at the grotesque inequalities and injustices in relation to health, these are the same inequalities, the same people in many cases who are affected by limited access to the right to education, limited access to water and to food. And I think we always need to take an intersectional approach in looking at this and look at how multiple criteria of exclusion affect people in complex ways, whether it's poverty, gender, age, sexuality, physical location. One has to take an intersectional approach to looking at the people we're working with and an intersectoral approach to how we will respond to some of those challenges. When I look at the sort of global governance of health, I think that much of what I have seen is a big part of the problem. That the global governance mechanisms have too much power and are far too fragmented. This is possibly a bit of a simplistic analysis, but I was at the Oslo Global Financing Facility replenishment meeting in December, and it just struck me with UNAIDS and Gavi and the Global Fund and the Global Financing Facility and others. There was a lot of attention to individual specific diseases and individualized responses, which are partly driven by the agenda of particularly notable billionaires. And there has not been much of a focus on strengthening public health systems. And I think, and having a more holistic approach. But one of the things which really struck me is when you look at how those global financing mechanisms work, all too often they lead to a displacement of domestic financing. And we've seen the same problem in the field of education. We had a case when I was sitting on this Global Partnership for Education, which is like the Global Fund for Education. The government of Uganda cut its own national spending from 17% of the national budget to 14% of the budget, and then went to the GP and asked for $100 million to fill the gap. Now that was replacing long-term sustainable domestic financing with short-term and unpredictable aid, and that actually does more harm than good. And as a result of that case, in fact, we managed to persuade the Global Partnership for Education to have as an absolute requirement that it would not give any money to a government unless it maintained or increased its own domestic spending on education as a share of the national budget towards 20%. And that sort of requirement, I think, is absolutely fundamental, because the real story will always be about domestic resource mobilisation, about governments financing public health systems through their own resources. That's how you're going to really address inequalities and injustices in the provision of health, and how you'll get to a position where you can challenge discrimination. However, as education activists, and I think that there's a danger that health activists do the same thing, we focus too much on the simplistic share of the national budget going to education. As education campaigns, we say 20% of the budget should go to education. I think sometimes I have a health campaigner saying we should get 15% of the budget. You get water and sanitation, people arguing for different percentages, and you end up fighting with each other for a bigger share of the national budget. And that becomes counterproductive in a number of ways, partly because you end up fighting with each other, when in fact there's a common cause, because actually an integrated response to the challenges is crucially important. But most importantly of all, a fair share of a small pie is a small amount. And the real structural problem is that the size of the national budget overall in many countries is simply inadequate to finance public services of any type. The tax to GDP ratio is a bit of a sort of approximate measure of these things, but the average low-income country has about 14% tax to GDP ratio. Now, those of you who are familiar with the work of Thomas Piketty, he says if any government has a tax to GDP ratio under 20%, you're just a regalian state, you're just a ceremonial state performing the functions of a state but not able to provide universal basic services. You need to have a large tax base if you're going to be able to finance credible public services. But what happens with the tax base? Well, we see all sorts of cases where governments are giving away what even the IMF would deem to be harmful tax incentives to attempt to attract investment from multinational companies. These are what the IMF call harmful tax incentives because they are incentives that no government should be giving away, because actually they're not really used to attract investment. Companies will take a tax holiday if they can get away with one, and they'll always try to persuade whoever they're investing in, whichever country they're investing in, to give them a tax holiday, but it's not the driving force for whether or not they'll invest in a country. Now, if you look across developing countries, $138 billion every year is given away in harmful tax incentives. And that means that's $138 billion, much, much more than the revenue that developing countries receive in aid, is just given away in order to apparently attract investment, foreign direct investment, which really shouldn't be happening at all. If you look at individual countries, Pakistan gives away $4 billion a year in harmful tax incentives as defined by the IMF. And I know what that means in the field of education. That means that every one of the 9.5 million children who are out of school in Pakistan could go to school, and you could employ 100,000 new teachers. You can get equivalent calculations for health, but I don't happen to know them off the top of my head. So harmful tax incentives, massive problem. They really shouldn't be given away at all. The other critical element here is about aggressive tax avoidance. We know that it's difficult enough in this country to get some of the biggest multinationals to pay a fair rate of tax, whether it's Amazon, Google, Vodafone, Boots, all sorts of companies who are aggressively avoiding tax. In low-income countries, this is infinitely worse because you have revenue authorities who don't have the capacity to secure, to make companies pay. The lowest estimates of the money that is lost to developing countries from aggressive tax avoidance is $200 billion a year. The highest estimate is about $600 billion a year, again massively greater than the revenue which would be coming from any global aid mechanism. And I wanted just one small example of this, because my favourite story of ActionAid did a study in Ghana of a large brewery in Accra, which was sort of making a very popular beer, and we did a sort of portrait of a woman who was running a small bar outside with a mud-thatched roof, and who was selling beer to the workers coming out of the factory where the beer was made. And we figured out that she ended up paying more tax than the entire brewery did in Accra. It's the largest brewery in Accra. And then we figured out that she paid more tax than the entire company did in Ghana, and it was the largest brewery in Ghana. And then we figured out that she paid more tax than the entire company did in the whole of Africa, and it's the largest brewery in Africa, SAB Miller. you make grosh and things like that. So you do need to know where your beer is coming from. But this is, it's scandalous, the level of aggressive tax avoidance. And this money ends up in tax havens and outside jurisdictions which are just not productively used. So there is a big challenge for how developing countries can expand their tax base, which would help them to invest credibly in all public services. Now, unfortunately, the IMF, who are a dominant voice when it comes to advising countries about how to expand their tax base, they constantly tell people that the way to do that is to increase VAT, value-added tax. That's the best way to do it, they tell people. But VAT is the most regressive tax you can use. It means the poorest pay a larger share of their income than the richest, and it therefore removes the revenue that would be needed by people for all sorts of other functions. And what we really need to do is to build a comprehensive picture of how developing countries build a tax base in a progressive way so that those who have got more pay more. And we've been recently producing a series of briefings on progressive tax. How do you look at how making income tax progressive? It certainly should be higher rate taxes of 70% in my view. How do you make corporate tax fair and progressive? How do you look at trade taxes and excise taxes, land and property and wealth taxes, capital gains taxes? We need to have a comprehensive vision of how to build a fair and progressive tax base, because that is how you're going to finance all public services. Now, having a large tax base, very, very important. I would, however, say that once you've collected revenue, the big question is, are you allowed to spend it? And this is the other area where I think there's a massive contradiction in global governance overall, and that is, of course, that ministries of finance are fundamentally advised and their policies that they follow are driven more than anything else by the IMF, and the IMF pretty much systematically impose austerity policies around the world. So governments, even if they have the revenue, are often not allowed to spend it all for a whole set of different reasons. But some of the conditions that are imposed by the IMF pretty much routinely around the world have a very, very direct impact on the capacity to employ more doctors, nurses and teachers in the case of education. For many years, they've directly imposed in 50% of countries around the world public sector wage bill caps, which meant that governments could not employ more doctors, teachers and nurses, because the doctors, teachers and nurses are the largest group of people on the public sector wage bill. So if you've got to hold down your wage bill, you can't employ more doctors and teachers and nurses. And that ends up in grotesque contradiction with countries where there are desperate needs to expand provision of health and education if you're going to get anywhere near achieving the Sustainable Development Goals. So when we're talking about global governance, the thing which really frustrates me is we'll go to these big global health meetings and the World Bank will be there, and they're partly complicit in this, but the IMF are never there, because the IMF say, oh, we have nothing to do with health or education, we just deal with macroeconomic stability. But it is those policies which alarmingly have been largely unchanged since the bad old days of the 1980 structural adjustment programs. They've repackaged them, relabeled them, but fundamentally it's the same package of policies still in place in most countries. The IMF have got a wonderful sort of doublespeak, so they'll produce lovely research papers on progressive alternatives and give the impression that they're exploring all sorts of interesting ideas which are more progressive, but the policy prescriptions in practice in developing countries are more or less the same. So, it is my view that if we're going to get serious about challenging the inequalities in health, we need to work alongside other public sectors and work on building a common cause across those who are working on inequalities in education and inequalities in water and sanitation and in energy and in all other sectors. And most of all, we need to build an alliance between the public sector forces and the tax justice forces which are growing around the world, because we're not going to get serious about financing public services without getting serious about the tax base. Thanks.
I'm going to wave it around as I speak. It is 13 years old now, but many of the concerns that have just been described on the panel are the same, effectively, as we were talking about there. Can I add a few notes of dissension? I think I'm going to just stir things up a bit. I may not believe everything I say, but I came out of global health activism having an intellectual breakdown about global health governance. And I think I'd better get that out now, as I've got it out to successive generations of students. So I was a campaigner and lobbyist for kind of between 10 years during my time at MEDAC between 95 and 2005, and that was in Geneva and Brussels, mainly in Geneva, so I spent a lot of time at the World Health Organization lobbying. I'm going to tell a few stories, so switch your Twitter machines off as well along the way, because it's kind of private reminiscences which might help illustrate some bits of global health governance and how civil society works in these situations as well. I would say, I think what Sarah was saying, and Gorick implicitly, and David as well, about the need to challenge global phenomena which affect everyone in every country is important. We have the Framework Convention on Tobacco Control, which has been a really good example of institutional innovation by WHO to do that, the world's first public health treaty. You have both suggested new innovations in these, maybe you could talk about that more. But the kind of grist I want to add to the mill is, having been and looked at global health governance and how everyone there says the same things need to be done in the same way. And it won't be about the IMF. They'll be criticising, as you said, David, the Ugandan government for displacing some of its own money when it could have done things differently itself, which was not due to the IMF. Yeah? For example, or they may say something entirely different. Yeah. And I wanted to just sort of illustrate some of the problems with some examples of what happened and what I saw doing this. And I was there at that time when global health governance really changed. When the Global Fund was invented, the Global Alliance of Vaccines and Immunisation, the Gavi Alliance, and the WHO was marginalised. And now, so why did all of that happen, and what were the effects? And maybe we can start talking about effects 20 years on now of this. Why it happened? Because WHO had gone through a period of appalling mismanagement under Director General Nakajima from the late 80s onwards, was put into recovery supposedly with Gro Harlem Brundtland since 1998, but she left pretty soon. WHO today retains the same, probably internal management problems that it suffered since then, which makes it a less effective organisation. We talk about the rich countries dominating these mechanisms of global governance institutions. Actually, a lot of the time, they're shooting themselves in the foot by ineffective management and constant changing of policies and people and not doing things consistently. We don't talk about it. Why not? We need to talk about it more. And one of the other big changes, I think, that produced the Global Fund and things was that there was a strong international rights movement for people with HIV. And as Gorick said, nothing was done during the 1990s. Absolutely nothing. And WHO was really complicit in this. A similar problem happened because in broader infectious disease areas as well, because partly as part of the World Bank health sector reforms, governments were encouraged in poorer countries to take on the management of immunisation programmes after really dire cuts of structural adjustment at that stage. And they couldn't do it. And all of those programs, many of them collapsed. Many of the disease control programmes collapsed. And so you got this huge clamour for global public-private partnerships, like Gavi and the Global Fund, but 70 others as well, because there were a lot of interested stakeholders saying, our disease is suffering. So we then got this plurality of global health governance, which was focused on diseases. And as Gorick said, who were the governors of these global public-private partnerships? Who were they accountable to? Well, it was very different to WHO and its one-member, one-vote system. And I think that's problematic. And I think it's part of the crisis of multilateralism today generally, that these institutions like the European Union, like the World Health Organization, perhaps, although maybe it's too small for anyone to be concerned in the end, are really under attack. And we've got to be careful we don't reinforce that attack in some way. And this pluralization of global health governance did. People did it deliberately. The Americans would not put through the money for extra HIV resources through WHO. I was told that directly by someone very senior at WHO. The WHO was seen as sclerotic, bureaucratic, because of all these internal management problems that no one is bothered to solve. Maybe we could have solved them. Maybe that would have been an alternative. Maybe a more coordinated and accountable route for the distribution of HIV and other disease funds, more focused on health systems, which I notice now everyone's talking about, would have been the outcome of a more WHO organised approach if WHO had the capacity to do it. Yeah, we will admit that was a problem. So I think there were big effects on accountability through this trying to get round the problems, the bureaucracy of the UN system, and it produced a crisis of multilateralism, which goes on today. And we've got to really think about the consequences of undermining that. Nation states are really important in these institutions. They fund it, they want some control. And I think they have a right to that control. Now this brings me to the second story. Really, the civil society lobbyists around the table in Geneva and other places looked like me, sounded like me, said the same things as me. Does this represent the diversity of world opinion? There's a very good paper by the political scientists Anderson and Reif about global civil society, which say that civil society at national level is the glory of democracy, because national societies have parliaments where people express their views through the parliamentary system. And civil society adds to that by allowing clamour to be raised for unrecognised issues. But at the global level, there is no parliament. And what you get is unaccountable global civil society organisations with the most money making the biggest noise. What do you know? This leads to because civil society is organised on disease lines in the health field, very disease-specific approaches, not for health systems, because there is no money in that area. So it was, this is why I had the intellectual breakdown, because I revealed I was part of the system in the end, and this was not going on. And member states were quite right. We were lobbying the World Health Organization for a greater role for civil society. And member states were saying, no, we don't want you. We represent democracies. We represent, most of the time, elected governments. We are more democratic than you. They weren't wrong. So who were we to do this? You know, we can talk about this we in global health. We've got to do this, we've got to do that. I think we've got to start questioning it much more. And that's again focusing on the local and empowering the local, and maybe not being involved so much at all ourselves is going to be part of the future. There's other stories I could tell about this one. I had just sort of flash through my mind meeting the Director General, going to lobby her about the need for more civil society involvement in global health governance. And she derailed the agenda entirely. That week in 2001, India and Brazil had attempted to get Gropal and Brundtland sacked because they had been ranked so low in the World Health Report published the previous year by WHO. This was an extraordinary, brave act by WHO, funded by its member states. It had ranked them in a report. The countries that were lowest down were furious. And they did gang up on her. And the first thing she said when we entered her office was, so you saw our report on World Health Report on health systems. Why didn't you support us? And she might have been right as well, I thought, years later. Because actually, WHO had done a brave thing to keep its member and paying states accountable. Why wasn't civil society brave enough to support her in that? The answer partly was she never asked us before. So maybe a failure of politics from the former Norwegian Prime Minister, but you know. There are things we could explore in this area about how civil society can support multilateral governance, is probably what I'll end on. And also thinking much more about the local and whether what we say is what really counts most. Thanks.